AI's everywhere. What role does that have to play in the future of aged care?
It's not only going to play a role just in the future of aged care, but just all of healthcare. I think it really will advance humanity. I think it will help us crack diseases. It will help us understand as we simulate medication efficacy. It will help us really make aged care better.
Welcome to Time Well Spent, the podcast for decision makers, providers, and everyone working to make a difference in care. I'm Dane Mitchell, joined by my co-host, Rose Plater.
Together, we bring 31 years of combined experience and still counting, and a shared passion for reimagining aged care and community health. From policy and reform to leadership, culture, and connection, this is where we explore new ideas, hear what leaders really think, and uncover what it takes to create environments where time is truly well spent.
Rob, before we get into it today, AI's everywhere. Rose and I use it for a lot of things, probably more than we should. But what role does that have to play in the future of aged care?
Well, I think it's not only going to play a role just in the future of aged care, but just all of healthcare. I think it really will advance humanity. I think it will help us crack diseases. It will help us understand as we simulate medication efficacy. It will help us really make aged care better.
Help us make better decisions, basically.
Better decisions, and then you can break that down. It can help us see risk. It can help augment activities. It can help our clinicians have more time, with their families if they're staying, after just put notes into a system where that can all just be recorded. Depends on the extent of which and where the providers want to go with it. But it really is part of this industrial revolution that we're going through just in 2025. And I think from a resident perspective in the families, it will help the really solve for some of the challenges within providers, even workforce issues. I think what we'll see is that it will even help in the way that different providers adopt it. It'll probably help them retain and even attract a workforce that just expects, a higher outcome than maybe what they're seeing today with either pen and pencil or some antiquated systems that
rather
they're
than
just
spending their time doing paperwork,
just doing paperwork, sitting behind it. I mean,
caring for people.
If you got into this industry knowing that, hey, I want to sit behind a desk and a computer and just put in notes and then report back to government all the outcomes, and then have to report back my time I spent every day in timesheets to do that, as opposed to really focusing on your passion and why you followed, what you did. That's where we can connect that to so many different use cases that AI will
so
provide.
what I've been hearing in some of the things that you've been putting on social is really a great excitement that AI can actually bring us back to what we should be doing, really being with our residents.
Being present.
Yeah. How exciting. And I think, just wait till, you'll hear more things about agentics, and, these are almost like little mini employees that carry out tasks, but these are mundane tasks. These are tasks that we don't want to do, or our RNs don't want to do. We want to really, focus on that activity, the human-centric element of it, and that's what it will do for us. 3 use cases are just examples of where AI will move the needle for anyone working in the sector, specifically the team members on the floor. It will be able to just capture pretty much everything we've done in a day and on a shift, and all of that information, every piece of dialogue, even the interaction with the
case
residents.
Notes for you.
Case notes, we can just automatically feed in, just by listening, just as if you're dictating to your phone in your car, looking at examples of names for the podcast. But that again just helps deal with elements of our multiculturalism, language, cultural barriers, all the things that we know just come back to some of the challenges with getting information in. So that would be specifically number one. It will help with understanding the prognosis of each resident before really the true preventive care, such as starting to see signs of symptoms of a UTI or delirium before it's actually gotten to a behavioural event.
Identifying and flagging risk factors.
You'll see temperatures starting to change. You'll see patterns that are not typical, but only because the way the AI is looking at it, we just don't have the capacity to have an RN just sitting and checking that level all the time of a resident. So typically it happens at the later event, and sometimes that leads to a fall or a hospitalization. Or probably the third one I'll share again on the floor side is one of the passion projects we've been working on is using some of the video avatars to really clone either a family member, or I clone myself or do some more of the media and other items. But if we put that into, let's say, the case of Claire Noland, the resident who was tasered by the constable down in Cowra, I mean, that event, it was just a travesty on so many levels because, unfortunately, everybody was following protocol at the end of the day. The constable, yes, it was bad judgment, but that was part of the protocol for an event like that, just not for a 90-year-old with dementia. But then why we let a resident to get to that point in that state also is we can do better than that, and we can use AI to either distract or try to settle. And so one of the things we're playing around with is cloning family members so that you can simulate either a Zoom call or a quick interaction to really just
familiarity.
Yeah, just distract. So I went through this with my father-in-law. He had Lewy body, and it's awful, because he would just be so determined. And he was very young; he was only 73, and he would effectively just get so agitated. And he was a big man too. None of the staff really, they were scared of him. They didn't know what to do or how to handle it, and so they would call my wife. But if my wife wasn't available, things would escalate. And he actually was handcuffed by the police when he was in respite care because they were concerned of his level of agitation. So in that event, I would be using AI to just clone my wife and sign off and allow the provider to use that as a tool or intervention to distract him and have a conversation. But behind the image, behind the person who's identifying with, is a language model that has been academically developed with the best behavioral de-escalation approaches, strategies. It's been trained. It has the guardrails, all the things we expect before it gets deployed, of course, but it would really engage and read what's happening, tonality, and give a sense of where that resident is, and then choose the specific words based off the research and feedback that the model's been trained on to safely and address the situation like that, so we never have that problem again.
That's really interesting.
So
that's very interesting.
So the three things that could sell to somebody who might not or might be a bit afraid of AI, you would suggest that it would be one in reablement or in for health promotion, understanding what the clinical data is saying early and prompting the clinician to look into that diagnosis or deterioration to help us with our documentation. So we're not spending hours rewording what we've just done for the day, that it can prompt us with that. And the third, which is the most exciting thing you've spoken about, I think, is this idea of being able to clone our loved ones so that they can be a tool for a clinician to de-escalate someone with dementia.
Or some of those advanced behavioral situations that, again, are a different category of what residential aged care. Like there's behaviors, and then there's residents that have those challenging behaviors. And it could also be of that family member when they were 20, 30, wherever it's appropriate, but that's exciting. And I think also I never would want a family at all levels, from the CEO of that organization who it's been very tough on them, from even the constables' families, because he got up that day just to do his job, and unfortunately it just landed how it did. And then of course, Claire's family, whereas now we do have the technology, and it can get there, and it's already there in different countries and different elements with post-traumatic stress management. We have in Japan, I think they use it with families that maybe lost young children and help them deal with that sense of loss, where they can interact in a VR world and spend time to help with that sort of grieving process. But there's so many elements. But what I love about it too is that it's not always just going to come from organizations like MIRUS or others. It really comes from a lot of the individuals at the coalface, and I think that's what's so important is that, and why a lot of these technology vendors need to understand the industries which they're servicing, because so much of what's occurring is really coming out of the floor, and even you would have feedback going, "Oh, I don't like how this feature works." Well, that's insight. I mean, someone in behind a computer building something isn't going to know the permutations you're experiencing it. So that's very important.
You've argued that aged care doesn't have a revenue problem, it has an efficiency problem. Where are good providers losing the most ground?
Yes. Well, I think the efficiency is a tricky one now, because it comes from a mechanism of funding. And really, that's the foundation of how the new standard, which is a care minute target, needs to be met. And what's happening is there's a lot of groups that still run a revenue function like the yesteryears. ACFI was the previous instrument. And so that was all about top line revenue growth, or ADS, average daily subsidy, just keeping it moving upwards and really looking for deterioration, not reablement, just deterioration, and grabbing and then filing away. And with ANAC, we can't do that. And so really the model of care around the site is the baseline. And so I think the reason why it's complex is that you really need to start there with what the model of care and what the facility needs from that baseline roster, and then think about how you efficiently stack it. Otherwise, what we see is a lot of groups just chasing the tail and really trying to achieve a delivery of care that is, the workforce isn't there. And that means you have a lot more penalty rates, you have a lot more overtime, you've got a lot more agency usages. And that's drives killer, right? A lot of the efficiency in that part. But I think also with where the world's going with the AI and other ways and practices, I think that efficiency will come into a balance, but it does start with really some of those fundamentals. And that's what we see as a long-standing revenue management consultancy, but also inside of the technology, but also delivering a lot of that education to teams over the years. And even with ANAC, when it was introduced, we delivered over like 300,000 of free training for the sector. And it was...
I attended some of those, by the way.
Oh, did you? It was really great, because it gave us that coalface feedback as how is this going to work? Where are some of the teething problems going to arise? And I can tell you, not one payroll rostering clerk attended, even though you think about that mechanism. It was a lot of funding managers, care managers, allied health teams. And I think that speaks to a little bit of that. So I think we need to do some unlearning with the old ways of working, but also be open to this change and embrace it, because this is a very different world of operations, and it starts with that efficiency, how the rules have been set for the providers.
So you've built MIRUS around data long before.
Data, we say sometimes.
Data. We're in Australia, mate. Where did that obsession with data start? And how does it help how you think about AI?
My background was, I always struggled in stats, and I remember taking courses in uni and just going, oh my gosh, what is this? And I had one stats teacher really put it into a different framework, and talked about probabilities of getting a more beautiful girlfriend if you left the other one. And I was like, okay, this is interesting. Now I'm on something. And when I finished university,
is that advice? Is it?
Was your stats the hot crazy matrix? Or
I mean, they were all in there. And this guy was out there. He really
he made it relatable to the 19-year-old.
For university kids. And I was playing ice hockey there, so I was student athlete too. So I was like, okay, now you got my attention. I'm focusing on this. But we really, it came later. So I've always been involved in sports. But when I graduated, I worked for an IBM company out of university, and it was their statistical department called SPSS. And one of the first jobs that they came in was the Oakland Athletics. And they famously were working on this statistical metric called sabermetrics, which was really the basis of what the story of Moneyball is. What you've seen the movie with Brad Pitt and Jonah Hill. And I'm not Jonah Hill, that was another guy named Paul DiPodesto, but his team would work with our engineers, and I was brand new to the firm, so everyone remembers that first job. But what they were doing was really starting to collect data data points on all aspects of this game of baseball, which at the time, like a new baseball, but just like cricket, it's a data intense game. And they were looking at it through the lens of where they can buy really players that would allow them to perform. And I thought, wow, this is such a different approach than I've seen in professional sports. And then they literally almost won the World Series that year with a budget of just over 30 million against the behemoths, the New York Yankees. And that job just stuck with me like ever since. And it also brought a lot of the insights of what I felt I wanted to make sure industry or clients, or when I had spent about 6 years at PwC, and everything was about measuring data and having performance improvement through benefit management. So it just kept coming back to the core foundations of what we could show clients as, the value you create, but then having it measurable. But as we then started to explore this in the context of operations, we then started to create our own view of it. And that's what came with the idea of MIRUS metrics, as sabermetrics, a little bit of a nod there to it. But we started looking at operational data points that would drive efficiencies or show and tell a different story. So things like the 4B utilization rate, the voluntary ACFI submissions versus mandatory submissions, all different ways to look at how performance can be measured. But it all came back to really those early days at IBM.
So through the provider's own data and that of others, you give leaders transparency on the information that they have. What cultural changes do you see then happen?
Well, so much, especially with the way AI is taking and transforming organizations. And it really is transformation. I think for the leaders today, what it provides to them is, let's even break it down into personas. For boards, it gives them a relative comparison of their operations to industry, to even different segments or cohorts of either operations within the business or just peers. Maybe you want to measure yourself against the other not-for-profits or private operators. That's something big that our sector loves. But the boards then feel more connected and understanding when you can just show some of those insights for them. But then as you get into more of that operational nuances, in the ACFI days, it was really about, I guess, highlighting a world of the financial activities that go into the clinical delivery. And that's always been a bit hard, I think, for providers, because let's just say CFOs don't do so well on the floor, and they're not really like looked upon well by the clinical teams. There's, both have your swim lanes and you don't cross it. But unfortunately, there's a box that has something called government entitlements, and it's about 70% of the revenue they collect. So that's always been a bit of a dark mystery, I felt, until I at least got into the industry when RCS and ACFI was changing. And I could see that both from the transparency to the operators was just a leg up. They started to understand more about a business function that for 3, 4, 5 years they've been running it. They just let so-and-so do it. And it just worked, and they kind of always landed right on budget. But then enter MIRUS and Rob and the teams, and we started to really open up dimensions. But where this is now going, other than just the reporting, is that information and data are really the building blocks of how AI and a lot of the automation will work. And what will start to happen is that many of these organizations and what the technology will do, if they can have good data that they can structure and feed in a way that really progresses some of these, the new technology of AI, they will be able to see risks that what they would have had to employ clinicians to manually read through care plans and see if directives are being followed, where that sort of synthesizing information and really augmenting tasks, which it's kind of a mundane task, but it's going to continue to evolve, but in a good way, in a way that it's not going to, I know there's a lot of people that get fearful of replacing their jobs. I mean, we used to have switchboard technicians. We don't have them anymore because it's done by computers and, routers.
So could you on that give like a real world example that's happening maybe out in one of your clients today around automation and how it's saved
Absolutely. We there's a dreaded report called the NQIP, which is the National Quality Indicators Reporting, which is a long and it's quite mundane process for some of the top clinicians to undertake. And we have a number of different clients, some using 2 different care management systems within a 400-bed operations. And it takes them 80 hours of these clinicians' time a month to pull together just parts of that report and also feed that to the board. The automation and what the AI has done to that process has brought it down to about 3 minutes. And so that's just an example of valuable time that 80 hours could be redirected. And that's where
2 weeks full time to 3 minutes. It's pretty amazing.
To still drive that outcome. And that's just the beginning. There's cases where we're even have a project we're proposing to the Department of Health to really look at the process of this contracted allied health and other RNs who are the AMOs and really focus on that deterioration, or rapid deterioration residents. So that's where they're getting still a lot of noise from providers. It takes 4 or 5 weeks to get a contractor to the site to review a couple of residents and they pass away. It does feel a little bit unjust to the provider side that they still have to wear the cost of that in that process. So in this example, we've effectively used probably the most technical use case, a generative AI model. So that's really 3 different language models that are communicating with each other, but they're communicating with each other over the department's algorithm. So the first question is, can Rob do a bed bridge in the DEMI assessment? And so that's not a typical assessment we use in aged care. So we have to teach the models to infer, but the first model has to go, well, I know where to find all of the information that we could look at to determine if Rob could do a bed bridge. And then it goes and grabs all that, brings it back, and then hands it off to the next model. And that model then goes, hey, all right, bed bridge, I'm looking through it, gathers all the inputs, and then even goes through progress notes that can see, well, this one was to Rose, it wasn't Rob, so that's erroneous, let's take it out. And then the final model then reviews that work and then gives it an on balance, say, listen, I don't think Rob can bed bridge, so we're going to go no with that. And then it references all that. It does that instantly. So that's really just the power of some of these outcomes and where this can go.
For a lot of providers, that's going to be hard to get their head around. But genuinely, but I think from, people in our space, working in professional services type roles, like clear use cases right now for AI, for example, preparing for a podcast, extremely useful. Would take Rose and I
content, social media,
all that, right? Like that's a clear use case. What I'm really interested in is how you can see the clinical use cases for AI and what work you're doing around that. Because I think what I'm cautious, both Rose and I are on boards for not different, but not-for-profit aged care community, small community providers. I'm really interested to see the use case for in clinical services, because I can understand, in my allied health business, we've got case noting, report writing, we've got some awesome tech built within our practice management software, which is saving the team heaps of time. But I'm interested to see how we implement that with a personal care and a clinical care workforce within resi and community care, because I think that'll be a really challenging staff training exercise. So what's your thoughts on how to do that?
Well, it's already happening. We had a client who we used a model in the States called Generation Health. And it's got about 200 million patient journeys mapped through it. And we use that model to push through current markings of residents, of where the care plans are, what diagnosis they have, gender, cultural background, all the things that are sitting in our care management system side of it. What it does then is it looks at those attributes and then it simulates the future of that resident. So really saying, all right, within 3 months, you're going to see a marked deterioration of mobility, and really getting down to the point where you can see month by month how that is playing out based off of all the different.
That's a predictive
outcome. And the way that we used that was not just to say, all right, well, that's insightful. What do we do? Because, my father-in-law had Parkinson's, and that was a new condition I've never experienced with. And I didn't know what do you do as a family? And, what we learned is that you have to do a lot of mobility, a lot of balance, a lot of strength training, more physio, So we're like, okay, let's get more of that in it. So in this process and actually looking at it, this was at the time when the additional services and the health fees were coming out. So this was really about creating a very specific and targeted offering for different types of residents that have some of these markings, such as the Parkinson's or skeletal changes and differences, and then to really, as a provider, design very targeted services and offerings for families that are dealing with some of those conditions. So that we now have the Parkinson's Warrior Clinic. So that's now available, but now they can explain to the families, listen, this is the journey that mom or dad's going to go on. In about 3 months, the models are saying, we think they're going to start seeing some marked deterioration with your father. So what we need to do today is to preventative health. We need more exercise. We need strength training. We need to build as much muscle.
So how do you build that within, if you think about, like, Rose has been a care worker, and one of the challenges is, like, clearly that's valuable information and would be really helpful to a family or to a care worker or to a physio in aged care. But how do we build that into software that's easy to use, simple to use, and it's accessible? Because I think the risk we have with, there's a lot of tech solutions. We all exhibit at the Aging Australia conferences. So
there's a lot.
Every other booth is AI related right at the moment. There's lots of different really useful tech. But I think sometimes the challenge is, how do we implement it on the ground with a care workforce which doesn't care about Rob's great solution?
It really comes down to how available and structured is the data that these businesses can have, and what some of the larger enterprise groups are doing. They're mapping 50, 60, 80 different pipelines of systems and information into these data lakes, and then structuring them in a way that you can overlay that in a controlled environment. This isn't about just pushing this up to ChatGPT and sharing it with the world. This is really,
how do you simplify it down to
that's
what's actually needed?
That's right. It starts with the building blocks. You need to be able to provide that information and those markings in a format that some of those, like this model we used was a prediction model. So we really had to transform the data to feed it there. In the future, that will become much more available inside of the ecosystem. But the barrier we have is that so many of our providers in this operations of 200,000 beds, we have so many variations of systems and silos of information, and also we have vendors now starting to block and say you can't have my API, or we don't have that, or playing some of those games, and that's a little bit of the barrier. But part of my vision is to really bring one system that covers everything like an SAP would do for operations, and that's really just continuing the story of the first aged care ministers.
Do you provide your own, like, clinical management software in aged care?
Yes.
And you've built that in.
So what we've done is we've acquired the business and management advantage of, it was actually Peter Staples, who was Bob Hawke's health minister. He was the first aged care minister. He also invented the TGA,
big Bob Hawke.
PBS.
Fun fact. You want to share your fun fact?
Oh, yeah, Bob Hawke story.
I have a
beer sculling story.
The beer sculling story. I wouldn't have that one.
Yes.
We have to now.
Oh, no, I don't think. I may have also won a beer sculling competition at Bob Hawke's, one of his favourite pubs, when I was in Young Labour once upon a time.
Fantastic. I love that.
But the story that I was going to share is that I own a pair of jeans that I wore when I was in 16 that are signed by Bob Hawke while I was wearing them, which was very exciting.
Wow.
So showing my age.
I'll have to tell Peter that story as well when he's back from Europe. But yeah, so Peter really, when he created the standards in the Aged Care Act and really brought in that first federation of an industry of convalescent homes, he could see where the need would be and how computers could assist clinicians in delivering these outcomes. And I also come from a family of my grandfather ran the Noumea Hospital in New Guinea during the war for 4 years.
Brilliant.
Got a lot of nurses and teachers on both sides of the family. So there was always this, subconscious calling. And also when I came out here, I remember using Manad, or Manad Plus as it was called, as to look for information.
What's that?
That's the care management system that he created.
Gotcha.
But he built it with his wife. She was running Assisi Homes down in Victoria, and they really built it to help providers comply with the standards they've created, to clinically document and create best practices, even provide an ecosystem for nurse advisors to come in and actually run their own audits and design this all. I'm just talking nearly 30 years ago, and fast forward today, here we are with the new set of standards coming November 1st. The industry going through the same reform change that it achieved back then.
Constant regulatory change.
And I just love the story of Peter and his legacy. We're continuing on, but really what I'm just bringing in as a custodian of that system is just elevating it to the next generation, and also enabling more of the the data and that AI enablement layer and the innovation side of what really are just longstanding principles of how the key standards were originally designed that are really inherent into that system. So part of our vision too is that we feel that providers, they shouldn't have to go between so many different variations of systems, and that just adds more and more complexities to this vision.
Probably where I was going a lot with my question is it's great to have all these tools and AI, but if it doesn't all integrate and doesn't make it seamless, and it's you just won't get. I don't expect that you'll get the staff uptake, and you're just creating cost and complexity. And we had Stu Hutchin in here earlier today, and he was talking about the average age of the workforce in aged care was 48. Is that right?
Let's go with that. Yeah.
50, and maybe it was 48 for aged care, 50 for home care.
Mm-hmm.
It's around that number. That's not a demographic that's grown up with technology like
low adoption,
like we have, right? So, and that's the average age. If you go to a lot of the clinical staff,
half of them are older, right?
Like an example of that is how many of those clinicians want to, this is where AI can help, spend half hour after their shifts, and they know they got to pick up their son or their kids, and they just need to get their notes in, but it takes them a while to do it. And so these are some of the areas that the AI will certainly help evolve and really augment that. But what Peter shared with me is that when they first launched the system in the early 90s, literally it was hand on hand with the clinician, and then driving the mouse, click, and then drive the mouse again, click. And so those days are a little bit varied. So we're moving on a bit, but certainly the UX, the UI and design of it will assist, but the fundamentals are the information and how data flows between these disparate systems. And I think the
predictive side of what you've explained, I mean, I can see so much value in that from we're physio provided aged care. We also do occupational therapy.
Yeah.
There's real value in that, especially if you've got data at the scale that you have access to. Look at every
sports team out there, the Swans, Western Sydney, you name it, they would have every stat being measured on those players. They would know probabilities of injury, hamstring pulls,
fatigue,
calling you out.
Just if you think about what the average care system does today in market versus the Apple Watch.
Yep.
And the Apple Watch would be light years ahead of what most care management systems will tell you about the clinical data of our current clients.
Yep.
Do you think there is that education piece and conversion piece with the head clinician to really understand what they could be taking advantage of here?
Absolutely. I think a lot of the systems have been sold on little features that a clinician really likes, but without the context of everything else that's also important. And that's where I see a lot of I call it the noise, but a lot of overseas have seen what the governments are putting into home care, support at home, residential aged care. I also know that there are investment philosophies where big money wants to come in and buy critical assets and data and the businesses that run that. And I think we have to be careful with certain sovereign technology and companies that we can't let it just be run by anyone, because now we're a bit beholden to a different country and what they have and own. It's kind of like when Australia was selling ports and other assets we have. These are critical infrastructures, and we need to think about our data and our technology, but also we need to have more standardization. I mean, we don't even have one resident agreement out right there. Imagine buying a house right now and you have to go to every open house, you're getting a different contract. Go, okay, well, you know, I'm talking to my conveyancer about this one and that one. That's what a family's going through. So we need government to actually drive more standardization for the sector too. The law firms would probably be the ones to be missing out on it. But if we had some of those basic templates, these start to really move the needle in efficiency. And think of just all the internal organizations that now, if they have one agreement, their heads of a mission and some of the finance teams that really oversee that, it becomes easier for them. And it's that lightening of the load and the, I guess, taking an industry that's gotten way too complex for the size of what it's doing compared to some of the other markets I worked in healthcare, such as in the States, and that's got its own complexities, but it's more of the private insurance side of it, whereas we've got one payee with Medicare and Service Australia. But I think we can support the sector more by really helping the clinicians that are probably working at 3 other providers at the same time, but they've got to jump through 3 different variations of care management systems when they take the afternoon shift because they've worked the morning shift over here. And then even going back to the first question, I think there is a lot of efficiency there in how we approach our strategy with sovereign technologies and really being and having some hard discussions about is it time now to really look at, what are and who are the people behind some of these companies, and are they in the best interest for what we're trying to achieve in our sector?
I was just going to say, you're trying to keep the Americans out. Is that what you're saying? I know you're Australian now.
You got Aussie now. Only got one passport.
MIRUS certainly got a lot of market traction around the ACFI model and the ADS. I was, a manager at the time, and I was doing the daily update of the ADS. And that was, a dashboard to get a bit addictive, particularly when you're going the right direction.
Yes.
What you're now doing is really looking at the other side of the equation and looking at costs and as well.
Yeah.
How close are you to being able to start tying quality of life in with some of these metrics?
We're getting closer to quality of life measurements. We do have a client who's working on, and I'd love to say because they're a beautiful client, and he's a great leader in Western Sydney. And
well, if he wants to come on a podcast,
regional operations, 22 sites. But that's exactly what we're working on now with some of those the approaches. I think though, the quality of life is difficult. I mean, right now where we're at with most of the sector is just helping them get on top of care minutes and this funding equation. Because on one hand, the revenue is setting
fixed, right?
Their targets.
That's what you can.
Yeah,
that's what you've got to do.
And then the other one is setting their actually supply, or they can see it. They can't even see that as they sail through. So we're at a point where we're just helping them first to see how fast they're traveling, and in the context of the new standard, which is the care minute targets. The next thing, as we start to continue to build on that information, is that we now will have quite a bit of data on the clinical delivery and look at it through different lenses of minutes, staff roles, even some of the QFR reporting has all sorts of the different roles and quarterly financial reporting that the providers have to give, and they have to break down specific roles, direct care, non-direct care. And what the department has done with that is they're approaching it the same way. They're really looking at all the components of how these businesses are working, whether or not they're sustainable or not. And I think when I was listening to Richard Colbeck speak about this system, probably about 7 years ago, I think when someone yelled out from the back of the room saying it's going to be like Minority Report, or the commission's going to come through the windows before there's a fall or there's an event, and really that's part of the department moving us in a direction that we can start to see risk in financial viability, risk in care delivery, and then ultimately risk in the well-being of the consumer, the residents, the people that really matter at the end of the equation.
And the exciting piece is that a lot of that vision and transparency, I guess, on all of those things at this point in time is coming at a huge cost. You talked about 80 hours.
It's a lot of manual effort out there.
Don't focus and invest upfront on our systems, on automation, then we're going to be making a rod for our own back, right?
Yep.
Where the cost is just going to outweigh to get the data to where it needs to be any viable opportunity.
Yeah, a lot of times there are also tasks that, I mean, these are some of our highest paid RNs are doing manually, and they're not working with a resident or working with a family or explaining, what the prognosis of the Parkinson's journey is going to look like. They're literally going through 4-5 different silos of applications to try to pull together a mandatory report. That's going to be the first sort of phase as we go through it. I think the next phase is going to start to feel a little bit weird for people, because in the next phase we're going to go through, you're going to start to see almost in a human services industry, we have I guess in a different setting in terms of we profile our employees, and we used to do this at PwC where we go through this HBDI sort of what type of brain are you and how do you think,
how balanced are you,
and we've got the reds, and they're more people.
You didn't do all that in Yamba, right?
It's exactly what cliches, there's a lot of feeling oriented people that think with their gut, and so when you start having computers and algorithms start to represent humanistic, almost relationship type of, you rely on then this interaction. It feels very human at first. That's going to be
a challenge.
Because I think our sector is going to have a league. You get connected, and you're like, oh my God, I'm speaking to the Gemini, profile that I've set with the English, accent. And
we had a bit of a scary moment the other day. We're talking about the title of our podcast after the title of a particular episode of our podcast, and I was driving in the car speaking with Dane, and I suggested the title. And literally he's typing it into ChatGPT at the same time, who spits out word for word the
identical
title, as I've said it.
But I mean,
it does listen, but not that fast.
Oh, it does. And if you have that on more of that, because I mean, think about that adoption of technology. We'd rather just talk to someone. The next thing you know, you're talking to the computer's talking back. You have now a relationship happening. You can change the accent. You can make male, female, whatever outcome. And that will start to, I guess, throw people into a different way. It did for me. I mean, the first time really engaging and talking, you almost forget you're talking to an algorithm, but you're in the moment, in the discussion. So it's going to go through that. But then the other component is that there are controls around this too. So for instance, the TGA does govern technology as well. Like a lot of people think about, it's a new medical device, it has to get TGA approval or a drug, but technology is also governed by it. So if we are providing decision support or there is a clinical judgment made, there needs to be a TGA approval of how that came to that conclusion. It's even in the new act. And so I think as a result of that information too, we will have what they call human in the loop. So therefore we will need to be able to check and give the clinician further evidence, say, well, do you go down this path or you go down that path? Because yes, there's been things, but models do hallucinate, and we still have to make sure.
Yeah,
that's right.
Interesting. You've been talking a bit more recently about the bed blockage epidemic. What's driving it, and how can we use tech to solve that?
It's getting to be a pretty bad, epidemic. It's we even have a colleague who's just got diagnosed with stage 3 breast cancer, some rare form, while she's 36 weeks pregnant. And unfortunately, I believe even her procedure had to wait based off of some of the
And this is bed blockages in hospitals, right?
Yeah.
Yes.
Yeah. And so some of these outcomes are really about deploying, and I make the caveat, I did start in health here doing patient journey design in the acute sector. I know, and I mapped out and I worked with a lot of the different wards and different stakeholders at hospitals, and you would see some of the nuances. It's like watching traffic back up because somebody cut in and then they braked, and next thing you know, it's brake, and then it just compounds behind. And in that event, what's effectively occurring is there's a lot of strategies that need to come together, and that's part of it. But how we can innovate around it, and what we're doing is that the hospitals know when a resident or patient is ready for discharge, and they can predict that, and they'll sign off on that. The problem, at least part of the problem where we're at right now, is that
finding certain cohorts of, let's say, patients that just don't rise to the top of the list for admission. So they're bariatric residents, they're the psychogeriatric residents, and then dementia residents. And on average, it's like 6 weeks past their discharge date, a dementia resident is still waiting in hospital. Now that has the knock-on effects. But where the innovation's coming from, and at least where we're exploring it, is again, using more of the data to enable the insights to connect our sector of aged care and also home care and other sort of alternative accommodation models. Because remember, this is a patient who's been signed off by the hospital to go home. It doesn't have to be residential, but it needs to be not in the hospital. But just starting with the insight of saying, all right, today we have 3 beds available at this home. We've got 20 over at this home. We have a home care provider here, but making that information just readily available without inputs from the residential side, because we can't expect, if we're going to be part of the solution, the acute sector can't expect the aged care to just have to wear all the administration burden of then keeping a database up and telling when it's available. Well, firstly, we have the data. We're exploring what other insights do the aged care providers need to know about that, because there is a distrust between the two. And that's the harder element to really break, because they've had too many experiences where patients have come to them and it's not what they expected, or they can't deliver psychotropics at the level in which a hospital has. And now they have a different issue on their hands. Yeah. So there's an element of really breaking through some of that, but it does start with the data and that insight piece, another dashboard. But at least now you have a conversation and you connected 2 parties that otherwise aren't talking today. And so that's where we're exploring. Other groups are even going to the extent of buying some of the old HealthScope hospitals to look at this logically, like a logistics problem, and then move. But then you still have a lot of the state and Commonwealth government challenges in there. So we just really started something was simple and that's already running. And actually had a call with the department this morning on this, that we're going to pilot with University of Sydney, and also it's all part of Chris Marmolos's Whitting Group, who's the CEO, the collaborative healthcare initiative with about 30,000 beds.
They do great work with that.
And so we are going to be running that as a pilot with those providers to really connect the hospitals to the sector in that first pilot stage. So I'm pretty excited about it, but it's just another use case of how data and information can really solve complex problems, break it down.
You aggregate a lot of thousands of residents' data.
A bit of a hoarder. No, I'm joking.
We had a guest on earlier today, which will be, not sure it was a release schedule, but will be released at some point. But he's a partner in a cybersecurity law firm here in Sydney, Atmos Group. And how do you view the data risk or data risk, whichever one we're going to use, around, you're holding high risk personal information. So how do you view the uptake of data use by a broad section of the community? How do you see that from a risk perspective?
You can't take shortcuts. I mean, clients go, "How could you do cheaper?" I'm like, I wish I would have to put a server in my garage and then run, and I could be cheaper, but that's not how it works. I'm director, and we have the
obligations.
You have acts, you've got data privacy acts, you got all of these elements. Plus, we now have more transparency around that, so we can see ISO processes, and that's also about how the entire business treats data information. And I think if you are doing work with a vendor or a technology company that doesn't have these certificates, then you are playing Russian roulette.
Stop doing the work.
Stop doing the work. Because I mean, yes, we can all deliver things cheaper, but there's a component. Now, we've been doing this for 15 years, and we started when Services Australia was really just a bit of a minefield of rubbish. And also, let's say the ISO policies back then weren't great either, because I think every password was cake to eat, and cake to eat 1, cake to eat 2 just became the natural password.
I hope you don't have any vulnerabilities with that password.
We might have to hack an old Hotmail address.
We're now in the proto world now. That's a much different system. So that's a good example of how the department, the Service Australia. Everything's been changing. So in that element, we've also felt as a data aggregator, data evangelist, that we also wanted to see these practices being endorsed. So we were one of the first firms to really go out and get ISO. When people were asking, what is this ISO 27,000 something? For me, it's about firstly covering our own risks, and that's done with the extent of a lot of the processes we go through to manage this information, keep it all on shore, and work with some vendors. And this is back when even Google couldn't even provide the data on shore. They were co-locating their servers between Sydney and Singapore, and that's a breach to the actual data privacy back in those days. But I said, all right, we've got to leave Google. And yes, that was a big setback because everyone loves Google Docs and Gmail and those attributes. But we then had to jump into the whole Microsoft world. So you have to continue to make those sacrifices. You have to work with firms like that to keep you across what is the latest techniques, how they.
It sounds like you're saying it is risk, and it's something that you have to take very seriously.
It's always going to be a risk. I mean, if you look at some
trust
of these
is
companies,
so important with what you're doing, right?
Absolutely. But if you look at how some of these recent data breaches have been created, it comes out of really the employee processes around the control, and that's the element.
Or third-party vendors.
Third-party vendors as well. So there's endpoints. So also we have groups like CrowdStrike, which I know famously were known for the whole bringing down Virgin and Airlines for that update. But part of what they do is they really address the attacks and see that information, but also they're backed by other insurances to really help restore and compensate. I think they have Lloyd's of London behind them. So there's a lot of elements, but you cannot, I guess, sacrifice. And I think this would be an area that I would also like to see government to help out some of our vendor networks, because it does come at a significant cost. But because I look at the world through more of a data first, not a software type of mind, I've always just said, no, fine, whatever that is, we have to pay it because it's just part of doing business.
That's how you do it.
And as a self-proclaimed data hoarder, a lot of the data in our aged care system today is really compliance-based. There's a lot of box ticking, compulsory data. If you were to say, I think we should start collecting this data, what would it be in the sector?
We don't have the data that is, let's say, required for the standard automation. I mean, that's really what Inter-I and everything is about. I'll probably go there, is that I think we need more uniform data collection points. So one care plan, one assessment framework that we can then
basic templates
use.
So that we can start making.
That's part of, I think, Professor Len Gray up at U of Q, and part of his push for Inter-I, and he's got the extended quality indicators with that. So that would enable our industry and also the acute sector to now have a standard that we can start to share and be more, the word they use is interoperability at the same time. But if you think about it from sort of document once, collect once, or not even collect at all, it just kind of flows from what we do today. I mean, that's really what I would, instead of laboring to put more data capture on our industry, let's just do more with what we have and standardize it.
Standardized data collection protocols that makes it easy to compare later.
Yep.
Regulators are already floating ideas for automated quality reporting under the new Aged Care Act. If government moves to a more algorithmic scoring of providers, how do we keep that fair?
Part of that analogy with the ANAC project with the generative AI model is exactly that. I mean, that should just be something given. I mean, in our system, ANAC forecasts just come out of documenting the clinical outputs. These are all things that we expect our team members to put in the notes, do their assessments, follow the regular review process. But then we have to go back and spend 80 hours a month in that example just to then collate that to then report back up. So I think it's more fair to our clinicians and the team members, and also the workforce we want to attract in our sector. I mean, if you're at Western Sydney Uni as an RN today, finishing your degree, I mean, you're using the latest AI, you're probably on Atlas, ChatGPT's browser now. You've got all this technology you've just become accustomed to.
I'm on that, by the way. It's excellent.
It's pretty good too. But
it's really good.
And then you kind of come back to our industry, and it's like we've got an abacus over here. here. We're using a slide ruler.
What needs to be fair is that the assessment of it's accurate.
Yeah.
Right.
Okay.
Yeah.
So maybe accurate's the right word.
So accurate, that's also where, we know, we've seen it. You would see notes, you would review notes when you're on the floor. You can see where staff just copy this progress note and they go, oh, what's this? Looks good. Let's put it in here. And those elements there. But that's where I also see in that accuracy of the reporting side, these will create events. And a lot of it comes back to the system use. If you have to learn 4 or 5 different systems, and some of it may be the same system, but it's been bastardized 3 times over because that provider wants to use it this way, not that way. The end result is you now have a workforce that doesn't know how to put in the right information. I'll give you a great example we've seen with medication events. So a lot of organizations, they'll sanitize that because a lot of staff will look at that and they'll say, well, I missed the medication. And then they look at the boxes they have to tick, but not knowing that the system's treating that as individual events. So I lost the medication. Oh, yeah, I did that. I missed the time. Well, I did that too. And go through it. Next thing you have 4 events on that. And then the senior quality officer who may be overseeing 1,200 residents in a group, they now have to go through all of that, but it's coming from that foundation side of it. So I think the accuracy is something where it starts in that, our belief is having more of a standardized system that anyone who comes into the sector really has a baseline of what they can use, because our workforce does, again, move across different sides. They may work, it's shift work. So they're taking shifts wherever, but the accuracy can be improved through, at a foundational level, the type of systems and how we educate the teams. The next level up from that is really then starting to look at how we can do better with the information that's already captured. And so once we capture it, we shouldn't be manipulating it again and again and again and spending that time on it. And that's where, an example with this care minute area, we're ingesting data from all these different time and attendance systems, UKG, Human Forces, Day Forces, SIM, it goes on. I think there's like 21 different systems we now work with. But we're doing that because those systems don't have the ability for the rostering teams to report information or see this new standard of what's being delivered. But then at the end of the period, because all the data goes through one system, it's a single push button for your QFR. And that's where the accuracy is right, because now everything goes through one middleware layer. But then the other elements we just improve with process. So when you have the physio come in, or they're not clocking in, or you have an agency staff, we'll get them to follow the same process so we can capture that data instead of having to add it back and reconcile invoices. So there's iterations of that, but I think the next horizon after the rostering and the care minute conundrum is settled down will be in the clinical world, and we'll approach it the same way with accuracy, and we'll also be using AI tools to help transform and check and do those cross-referencing that a lot of data scientists would have to do. But that's the benefit of what's coming with this technology.
Brilliant.
Alrighty.
Rose, you've got a closing question?
Yes. Yeah. So this is our benchmark question we ask every participant. Participant in our podcast. Do you like being called a participant? That's a whole other
sounds like
podcast
an
episode.
I know. I'm a participant now. I'm a consumer. No, I'm a consumer. Yeah, the participants.
So if you wake up tomorrow, congratulations, you're now a consumer in the aged care sector. What changes do you need or hope to see?
A gentleman who used to be, he had a quality commission, he said this quite well, Mark Brandon. He would say, a lot of the consumers are more participants because they're just receiving, the outcomes. But I look at them as multiple. I look at them through 5 different lenses, because you typically have grandchildren who's probably found the site and done all the social media checks. They're even looking at Facebook and seeing what people are saying every day.
Reviews.
And then you have also maybe the daughter or the son of the recipient or participant or consumer resident.
This is your son now.
I've lost track on the references there. And I think about what can we do to really help the entire equation, around that, because that resident, that participant is just a fraction of what's going on. It's like an iceberg. Below there's a lot of probably guilt being felt. There's probably families on the other side of the country that are wishing they could be closer. And so I think of it through that lens. And where I go to with that is I start thinking about how can we then help all of that. And I think I reflect on my personal experience with my father-in-law and really reflecting on what wasn't, working. What did my wife, what was she not receiving? And she was receiving everything because she was the daughter who just was on the speed dial by the facility with her side. But I think about it in that instance, and I hope, and I'm, part of my mission is to drive, is to really provide that transparency through everything from, providing more insight of what's going on. Is the haircut today? Did we just achieve that? How do we encourage and foster, more communication or a better communication? So you're not like, oh, so how's the knee today, Mom? And you just talk about medical events. That's kind of where I think I'm going with my mom these days. I'm like, Mom, let's talk about something more constructive. I don't want to talk about all your medical events.
We won't send this to her.
Yeah. So it's it really goes to that point. But I think
someone just got to the bottom of the Christmas list there.
Yeah. No, mom's good, but hopefully by the time she's at that point, which who knows how far it'll be.
So what is the one change in 10 seconds? What would you like your future children to have?
I would want them to really get out of the technology, out of the provider, everything that they need to feel that I'm being looked after, okay, that they can see everything from the invoice, the billing, and understand it completely, that they are being kept up to date.
Transparency of communication.
Yeah, complete transparency to an extent that each family is going to be different, and each stakeholder in the family is going to need something more than maybe the other one, and all
and
of
maybe
that
at that time what you want to give them.
That's right. And at the core of that, though, is also just that pain and that void that I watched, my wife and her sister and my mother-in-law really go through it, and the frustrations they have when you don't see that, and you're just reacting.
Feel like you're chasing information.
Exactly. And I think that's really is the one change I really want to see happen, because it just can make families, let's say it's hard enough just out there with the cost of living and everything else that's going on, and especially with sandwich generations with kids and then parents going through it. What else can we do? And I think I reflect on my journey, and I just want to make sure every other Australian families going through this can really be present and have the best outcome, as opposed to, really worrying about things when they should just be worrying about the last hours, days, months, weeks with their loved ones.
If someone wants to get in touch with you, Rob, to talk about how you can help them at their provider use data to make better decisions, what's the best way to get in touch? 29487.
No, joking. It's reach out to us. I run a podcast on Fridays called All Things Aged Care, which I think we're chatting about
with Anthony and
MIRUS, Anthony and Owen. Great guys. We have a great. I mean, it's really touching when we open it up to the last part, to just have people all around the country just like call in and really hearing their stories from Townsville over to Perth and those aspects. MIRUS Australia.com. We're launching MIRUS Plus. Got a big road show coming up in November. Going to say a whistle stop tour, Kentucky tour. No, not really, but we're going around and really fun. sharing
Dane's
what.
Can I come?
Exactly. With Jimmy Barnes. Touring, going on tour.
Awesome.
But come to one of those in November. It's on MIRUSplus.com. And we're around. We're very personal. A lot of people don't realize we're a for-purpose organization. They just think, I guess, from some of the apps and technology, they just don't expect that to come from some of the businesses. But no, we really, and the teams that come to work at MIRUS really are all driven by their own why. And I think that's what gives us a unique advantage and really brings passion to the workplace. Hence a little bit of our work ethic discussion earlier. That's how I really get around it, is you really hone in on the passion. And fortunately in our sector, everyone has a why, and they want to see change. They want to contribute to it. And I'm just looking to try to do my best to enable it.
Well, Rob, data evangelist. I hope this was time well spent.
It was, and great to see you guys too again.
Thanks for listening to this episode.
If this was time well spent for you, follow the podcast so you never miss an episode.
If you want to support us, leave a review and share it with someone in your network who might get value from it.
Finally, a thanks to our partners who make this possible. Painters, your design and construction partner.
And Optum Allied Health, your physiotherapy and allied health partner. You can find the links in the show notes.
Thank you for listening. We'll see you on the next episode.